Hi everyone. This lecture is on assessing chronic pain in general practice. By way of introduction, my name is Nick Christelis. I'm a specialist pain medicine physician. I am one of the founders and directors of Pain Specialists Australia. I have come into the pain world through the anaesthetic world, so I was an anaesthetist first. I've got a long journey on my way to become a pain specialist, but effectively now that's everything I do. Through this presentation you'll understand why. So what I'm about is essentially ridding the world of pain. It's a big why. There's a lot of people in pain, which we'll get to in a little while, but this is the focus of my practice. I also want to improve the practice of pain medicine and neuromodulation as one of the advanced pain therapies. So this is the discussion we'll go through today. There's a lot there, so I'm going to break it up into something a little simpler. Essentially what we'll do is we'll have an overview of pain, then we'll have an overview of the assessment, we'll focus a little bit on examination of somebody in pain, and then that'll lead on to focusing a treatment plan, and of course how to use pain specialist in your treatment algorithm. Is chronic pain important? We all know that chronic pain is very important. This is the National Pain Strategy from 2010. Effectively, a couple of things just to remind you. 1 in 5 of us will have chronic pain at some point. The key factor is 80% of those people in chronic pain will not get access to the therapy they require. There are a number of perils that we face. If you have chronic pain, it's not officially recognized as a disease or public health issue. Friends, family don't understand chronic pain. Even many health professionals don't understand how to assess and manage pain, so I've had little training in pain. One of the big factors is patients can wait up to a year before they see a pain specialist. And this doesn't only factor for chronic pain, this is also important in acute and cancer pain. We're not doing as good a job as we could and should. The majority of chronic pain is managed with you in primary care, and a significant proportion of GP visits are associated with some form of pain. It depends on the numbers you look at, but up to 50% of GP consultations can be related to some form of pain. And only a small fraction of that number actually gets to see or get referrals to pain specialists. Again, depending on where you look, 2%, sometimes a little more. The cost of pain from Australia was released in 2019, and essentially this was a Deloitte Access report. We all know this, but pain is very expensive. In 2019, the total cost roughly amounts to about $139 billion. Now, if you have a look at diabetes, the cost of diabetes is a fraction compared to the cost of pain, about $7 or $8 billion, and that was in 2012. So the numbers will be different nowadays. What is chronic pain? So let's get into the details of the presentation. All pain that persists for more than about 3 months is deemed chronic, so it's long-lasting. Pain is a leading complaint. The thing about chronic pain is it leads to suffering, it interferes with function, and it is accompanied by high levels of distress most of the time. So it's a package that surrounds somebody with persistent pain. Most people ask, what is the difference between acute, chronic, and recurrent? Well, acute is exactly what it says. It's a pain that is there for a short period of time, usually caused by some form of medical condition, trauma, or surgery. Chronic, as we've said, is anything that lasts for more than about 2 to 3 months, mostly 3 months. And then recurrent pain is a tricky one. No one has really defined what recurrent pain means. Some say it's one episode over the past year of pain, and all the way ranging to pain episodes twice a week. So when you use the term recurrent pain, follow that with something clear in terms of what you mean. So this is the IASP, International Association for the Study of Pain, classification into pain disorders, and this was published in the journal Pain in 2019, and this was for the International Classification of Disease 11, so the ICD-11 update. And as you can see, I'm going to break this down, spend a few slides going over this because I do think it's quite important. Chronic pain. There's two types of chronic pain. There's primary chronic pain and secondary chronic pain. On the right-hand side of the slide, there'll be the secondary chronic pain syndromes. So focusing on the left side, chronic primary pain. This is pain that includes widespread pain, complex regional pain syndrome, some forms of primary headache and orofacial pain, visceral pain, and even some types of musculoskeletal pain, such as back pain, can be a primary pain condition. And then the secondary pain conditions, the right-hand side of the slide, you understand already, it's pain caused by something that we have defined. So cancer pain, surgical pain, so persistent surgical pain, chronic neuropathic pain, which we'll come to at a later point. Then you can have secondary headaches and facial pain caused by some illness. And the same thing applies to visceral pain and musculoskeletal pain. So that's an updated definition of primary and secondary pain syndromes. I'm just going to focus on a couple of the secondary pain syndromes, or a couple of these pain syndromes in a little more detail. This is the primary pain syndrome. So widespread pain includes fibromyalgia. Complex regional pain includes CRPS1, CRPS type 2. Then if you have a look, you break it back down, the headaches and orofacial pains, you've got chronic migraines, which can be a primary pain condition, chronic tension type headaches, chronic trigeminal autonomic cephalalgias, and the lists go on, and that includes chronic burning mouth and orofacial pain as well. Moving on to visceral pain, a lot of people don't understand that visceral pain, so pain within an organ of the body, such as the intestines, such as the pelvis, can be a primary pain condition. And that includes chest pain syndromes, epigastric pain syndromes, IBS, irritable bowel, and so on, including bladder and pelvic pain. So these are primary chronic pain conditions. And the same thing applies to musculoskeletal pain. You don't have to have a cause to get musculoskeletal pain. Cervical pain, thoracic pain, back pain, and chronic primary limb pain as well. Just a couple of secondary pain syndromes that I want to touch on. One is chronic post-surgical or post-traumatic pain. And post-surgery or post-trauma pain is a big deal. The IASP had the Global Year on Surgery-Induced Chronic Pain a number of years ago, and roughly, very roughly, the statistics are 1 in 5, some say even 1 in 4, surgical procedures can lead to persistent pain. That's a big number, which we'll come to at a later point. So chronic post-surgical pain, the big ones are amputations, pain after spinal surgery, pain after thoracotomy, a common cause of chronic pain. And the list goes on, pain after arthroplasty as well, so joint replacement surgery, pain after herniorrhaphy, which is a particularly important cause of chronic abdominal pain. And then you've got post-traumatic pain as well. I'm not going to spend too much time on these things, but I just wanted to give you an idea of how pain is now divided. Chronic pain after spinal cord injury, chronic pain after brain injury, etc. So again, this is chronic post-surgical and post-traumatic secondary pain. Briefly touching on neuropathic pain, I'm going to spend 2 minutes on this slide. You've got peripheral neuropathic pain, you've got central neuropathic pain. These are secondary causes. So the trigeminal neuralgias, the vascular malformations triggering trigeminal neuralgia is a secondary cause of chronic neuropathic pain. Anything that leads to peripheral nerve injury, anything that leads to painful polyneuropathy, postherpetic neuralgia is a very important one, and of course painful radiculopathy, which generally is caused by some form of disc prolapse. And then you've got chronic central neuropathic pain, and this is one that we all tend to forget about, pain after a stroke, pain after some form of neurological injury to the central nervous system. And of course that includes multiple sclerosis. Just to pause on chronic secondary musculoskeletal pain, again pretty straightforward, but you've got pain that is musculoskeletal in nature following an inflammatory condition, so infections, crystal depositions, and the inflammatory autoimmune inflammatory conditions. You've got the musculoskeletal conditions that are associated with some form of structural change. I hear a lot of patients say to me that the surgeon told me that my bones are brittle, they're like dust, they're turning to dust, and it's not true. We should be saying that your body is aging. Your body's not deteriorating, your body's aging. There are some structural changes that happen to all of us at some point. Osteoarthritis, spondylosis, which is effectively just degeneration of the spine, age in the spine, chronic pain after some form of musculoskeletal injury. And then you've got musculoskeletal pain associated with some problem with the nervous system as well. So example, multiple sclerosis. Yes, it's a primary neurological condition, or it's a neurological condition. However, you can get musculoskeletal changes because, of course, you move your body differently. You move one side differently to the other, so you can get knock-on musculoskeletal effects secondary to the neurological condition. Let's focus on some pain definitions, taking it back to a couple of basic points. Difference between nociceptive, neuropathic pain. It's important to understand the difference. Nociceptive is pain that arises from activation of nociceptors, so free nerve endings throughout the body. And that's arising from actual damage or threatened damage to these non-neuronal tissues. So that's nociceptive pain. And then you've got neuropathic pain, and that's caused by a lesion or a lesion or disease of the somatosensory, so the feeling part of the nervous system. Pretty straightforward. Pain of unknown origin is exactly that, pain that cannot be classified. But then if you look, there's a relatively new definition called nociplastic, allopathic, or nocipathic pain. And essentially what that is it's a combination of nociceptive and neuropathic, if you want to look at it that way. It's effectively pain that arises from altered nociception without actual or threatened tissue damage. So effectively what this is this allows us to classify those primary pain conditions that I've previously mentioned, like widespread pain, CRPS, complex regional pain syndrome, and some others, as a nociplastic pain. It's not pure neuropathic because there hasn't been a disease or a lesion of the nervous system, but it's nociplastic. In other words, that something has happened to the pain-sensing organisms. Pain-sensing organ. So as I said, it's a change in nociceptive processing. That's what nociplastic pain is. And this is probably occurring in the central nervous system. Don't worry too much about the busy slide. I just wanted to bring your attention to a couple of points. Sensitization, very important when you're talking about pain. What does sensitization mean? Well, there's 2 points to sensitization. One is it's an increased responsiveness to normal nociceptive input. So it's a heightened response, or it's recruitment of a response to sub-threshold input. And that means that something you shouldn't sense, you actually sense in a heightened way. I'll come back to that, but essentially sensitization is amplification of nociception, so everything gets amplified. And this can happen at a central level, so central sensitization, so at the brain level, at the spinal cord level, or peripheral sensitization at the peripheral nerves. And we all get peripheral sensitization when we have an injury. So you have a surgery, you get that area of hypersensitivity, swelling, inflammation around a surgical incision. And it's normally about 2 centimeters around a surgical incision, roughly. That's peripheral sensitization. If that area spreads, but you expect them to be getting better, then you might think, well, maybe this is central sensitization and the nervous system is changing more in the central component. 2 parts to sensitization I want to bring your attention to. One is allodynia and the other is hyperalgesia. They're 2 terms that's good to know, good to understand the difference between them. Allodynia means all, so think about all sensation hurts. That includes brush. So if you take a little brush on your patient's skin and it hurts, that's allodynia, so sensitivity to non-painful stimuli. And then hyperalgesia is an excessively an excessive response to a normally painful stimulus. So you take a toothpick, touch them on the skin in a normal part of their body, touch them on the skin in the painful part of their body, and it's an excessive or heightened response to that pain, hyperalgesia. So how do we assess chronic pain? Well, when I talk about this, I think about it in two aspects. We've got to assess the pain, and we've got to assess the person that has the pain. And they're two completely different things that are obviously interrelated. Whenever you see a patient with pain, you want to first find out if there are any red flags, any orange, yellow, blue, or black flags. So you want to alert yourself to anything that needs immediate attention, anything that worries you. We all get taught about red flags, so these are the medical conditions that you don't want to miss. You want to diagnose early, you want to get them treated early. So cancer, infection, neurological injury, Cauda-Equina syndrome, fractures, ischemias, and acute organ pathology. So are there any red flags? So somebody with backache, is there a Cauda-Equina syndrome? Is there changes to bladder and bowel function? Is there weakness? That switches on your alarm bells. People tend to forget about the orange flags, and that's more to do with psychiatric conditions. Is there a substance abuse problem? Is there a personality disorder? Is there PTSD and very high levels of distress or anxiety? So that alerts you to the fact that this is not just the good old yellow flags that everyone knows about, but this is more an orange flag. Yellow flags we'll come to in more detail at a later point, but essentially these are the psychobehavioral issues that you see in some people with chronic pain, not all, some. Maladaptive cognitions and behaviors, that means they're thinking and moving differently related to their pain. What are their coping strategies? What is their level of self-efficacy, which I'll come to at a later point as well. But effectively, self-efficacy is their ability to enjoy life despite what they've been put in front of or been dealt. So if you've got a high self-efficacy, you're able to enjoy a good quality of life despite chronic illness, diabetes, chronic pain. Low means you're unable to do so. So those with a low self-efficacy, a bit more of a worry. Fear avoidance is very important, so patients that get fearful of moving, avoid moving, and it's quite a common thing that we see in some people with pain. Anxiety and depression, you want to assess the family relationships as well, so you want to get a feel for family dynamic and what's happening on the family side of things. If lawyers are involved, if there's litigation, if there's compensation, this is clearly a flag, and it may alter patient's gain or other members' gain. So we call that secondary or even tertiary gain. Blue flags are their perception of work. So if they're fearful of re-injuring themselves at work, if they've got poor work satisfaction, and then the black flags are actual work conditions, manual work, unsociable work, working in the middle of the night, those kinds of things. So these are the things you're thinking about when you're making an initial assessment of somebody with pain. So coming back to the assessment, you want to assess the pain, which I'll come to in a couple more slides, but effectively you want to find out the pain score. You want to find out, is the pain neuropathic? Is it nociceptive? Where is it on the body? What does it feel like? When does it come? When does it go? So we'll come to that in a couple more slides, but you want to understand the pain, and then you understand the person with the pain. And that's how the pain interferes with life. What their self-efficacy is, which I've just mentioned. Are they able to still enjoy life? What's the DAS-21? So what's the levels of depression, anxiety, stress? And pain catastrophizing. Now, pain catastrophizing in a simple term is making mountains out of something that are not that big. It's feeling hopeless, magnifying the situation, and really ruminating, so going over and over a situation. And that's catastrophic thinking. And people with catastrophic thinking and pain generally have poorer outcomes. However, good psychological therapy can help. So a quick assessment of somebody with chronic pain is called ACT UP, A-C-T-U-P. What are their activities? How are they coping? What are they thinking about their pain? Are they upset? And how do people respond when you have pain? So that's a quick way for you to make a quick assessment of psychosocial aspects of somebody with pain. So this is the good old-fashioned history of pain. You want to find out the pain characteristics. We know that. How it affects the person, absolutely. And then you want to find out about the psychodynamic or social aspects of the pain, which I've briefly mentioned. So you've got the pain, you've got the person in pain. Signs and symptoms. Well, when you talk to patients, you want to find out what the signs are, what the symptoms are. And you want to work out if this is a nociceptive pain, is this a neuropathic pain, is this a nociplastic pain? Or is it a mixed type of pain? So these are the things you're constantly thinking about. Just to mention a couple of conditions associated with chronic pain. So if you have somebody that comes into you and they've got some medical conditions, you can already be alerted to the fact that they may have some kinds of pain. Medical conditions, there are many. Osteoarthritis, rheumatoid arthritis, multiple sclerosis, shingles, zoster, diabetes, very important cause of peripheral neuropathic pain, cancer, migraines, ischemia, and even angina. Some people with refractory angina can have chronic pain, a visceral neuropathic pain syndrome. Now, this doesn't mean that they shouldn't be getting treated for a proper ischemia, but those refractory ischemias without any blood vessel compromise can have some forms of neuropathic pain. And of course, surgeries and traumas can lead to pain. Just a reminder of some surgeries that can have high levels of chronic pain. We know about amputations, they can get phantom pain or stump pain. We know about thoracotomies, even the minimally invasive thoracotomies, a VATS procedure, can cause pain. So just because they've had a couple of keyhole incisions for thoracic pain doesn't mean they're not going to get it. Mastectomy is quite a common cause of pain. Hernia surgery, bypass surgery. I've seen a couple of people recently with persistent sternal pain following bypass procedures. Cesarean sections are there as well, so a very common procedure, can get persistent pain. Dental surgery, I see a lot of people that have had some form of dental operation and are left with these new, different, altered facial pains, and even simple things like vasectomies. How do you diagnose neuropathic pain? Well, it comes to classification of neuropathic pain, and you can either classify it according to the etiology. So is it a traumatic-induced neuropathic pain? Is it an ischemic-induced neuropathic pain? Is there infection or inflammation? Drugs, so chemotherapeutic-induced peripheral neuropathy, very common. Got to ask patients about it before they usually volunteer peripheral neuropathic pain. So patients with cancer, you've got to ask them specifically, do you have pain in the hands and feet? Compression and things like multiple sclerosis. Another way of classifying neuropathic pain is whether it's a peripheral medical condition or a central medical condition. So the central ones are spinal cord injuries, strokes, multiple sclerosis. And then of course the peripheral ones are something as very simple as carpal tunnel syndrome, diabetes, postherpetic neuralgia, etc. So think about the cause of neuropathic pain. This is something that a lot of GPs always ask me when I give lectures, and what about the other influences, the psychosocial influences of chronic pain? And again, I'll bring your attention back to the flag system, and this is a nice way of thinking about it. What are the, not necessarily red flags, but what are the orange flags, what are the yellow flags? So think about those flags in terms of how that affects pain. How are they thinking about pain? How are they moving their body? How are they coping? How are they able to enjoy their lives? What levels of anxiety and depression do they have? And of course, what's the family environment? And then you ask yourself about work conditions and perceived work. These are the factors that can influence the pain condition. There are many tools that are out there that you could use yourself to define neuropathic pain, define psychosocial aspects of pain. I just want to touch on a couple of them. Neuropathic pain, really easy to diagnose in some instances. You've got to just think about it. The DN4 questionnaire you can get off the internet and take you 2 minutes to find. It's effectively, I think, roughly about 10 questions. There are the 4 aspects to the DN4. There's a brief history. There's an examination part of it as well. And effectively, if you score more than, I think it's 4 out of 10, you're at likely to have some form of neuropathic pain. So is there burning? Is it painfully cold? Does it feel cold but hurt? Are there electric shocks, pins and needles, tingling, numbness? And of course, when you examine patients, you can either find three things. One is it's numb in that area that hurts, a classic neuropathic pain, or you can find hypersensitivity aspects, so the allodynia, all sensation hurts, brush hurts, or hyperalgesia, pain is excessively painful in that area. So take you 2 minutes to work out whether this is neuropathic pain according to the DN4 questionnaire. There are other ones, such as the PainDETECT on the right side of your screen, and that's what I use, or we use in our practice, the PainDETECT. And as I said, you're coming back to those validated tools. So the DAS-21, there is a pain catastrophizing score. There's a self-efficacy score and pain interference scores as well. So the brief pain inventory, the BPI as it's called. Examination, again, you want to exclude those flags. I'm not going to spend too much time dwelling on that. We've touched on this. But effectively, the principles of examination of a patient, again, I'm not going to go through the details. The aim is to, particularly for me, looking after patients in pain, develop a rapport. I want to define the anatomical cause or the origin of the pain. I want to define the mechanisms of pain if I can. So what are the pain generators? Yes, I'm looking for red flags. And then I'm assessing cognition, affect, and all the yellow flags. But effectively, when you touch your patients, when you can examine your patients, you want to understand if it's neuropathic or nociceptive or mixed. You want to understand the sensory component to the pain, so you want to assess the skin and see what they feel like. And then, of course, you want to assess the relevant parts of the body as well, differentiating impairment from disability and finding out how function is affected. All I want to focus on is the examination of the sensory nervous system. So that's light touch, brush, pinprick, temperature, proprioception. And as you can see from the slide, if you've got changes in light touch, brush, pinprick, you've got changes in the A delta and C fibers, which are the pain fibers. Same thing with temperature as well. That's why you're assessing those components of sensation to define pain. Just a reminder of dermatomes, we all know this. T4, T5 is around the nipple region, T10 is the umbilicus, and so on it goes. I will spend another 20 seconds on the dermatomes of the leg, because we see back and limb pain common. If you've got pain within the groin region in a dermatomal distribution, it could be L1. If you've got pain slightly lower down on the anterior and lateral aspect of the thigh, L2. L3 a little lower down, normally affects the knee. L4 knee and below, and L5 shin and down into the top of the foot and the big toe. S1 bottom of the foot and lateral, and then S2 straight down the back of the leg. Sensory examination. Hyperalgesia, allodynia. You want to define which one it is, or if they're both there. There are ways of defining hyperalgesia, there are ways of defining allodynia. I use a brush for allodynia, I use a toothpick for hyperalgesia. There are other ways of doing it. You've got the von Frey hairs or von Frey filaments. There are algometers as well, and there's a whole bunch of other things. But have a little paintbrush, have a little toothpick. Have something cold which you can compare as well. And it's quite common you see people that have sensitivity to something cold as well. And this is what an examination might look like. You examine a painful area, you work your way into the painful area, and you examine the sensory changes that you may find. Is it numb, but it hurts? Is there mechanical allodynia? Is there brush allodynia? Is there toothpick hyperalgesia? So let's go through a patient and through our questionnaire that I might see. So this is a real patient, names and a few things have been changed. The referral read as such. Could you see this 51-year-old female with persistent neck pain and left shoulder blade pain? That's pretty much it. There was a past history of a C5 to C7 fusion, so an anterior cervical disc fusion. This is the questionnaire. Pain started 2 weeks after the spinal operation. To relieve similar symptoms on that side, and the pain originally was there because of the patient was on a bicycle and was hit by a car, And they noticed when they saw the neurosurgeon, they noticed degeneration of C5 to C7 and this escalating pain which led to the surgery undertaken. You can see the pain diagram, so it's pain focused around the shoulder blade posteriorly on the left, and of course a long line of pain starting in the neck, just in the suboccipital region, all the way down. And you can see on the little finger of the hand as well. This is the BPI pain, so the top 4 dots, the pain scores over the last week, and then the bottom, I think it's 6 dots, are the BPI function, so the brief pain inventory function. So pain scores were moderate, relating from 2 to 6 out of 10, and the functional interference, as you can see, was also moderate, roughly down the middle. There were a few things at the bottom of the slides you can see. Wasn't able to reach above her head. She had bending was a problem. Washing her back in the shower was a problem. Sitting upright was a problem. So there was limitation to function. This is the PainDETECT questionnaire. As I've said, one of the ways we define neuropathic pain. 21 was the score, and normally anything greater than about 19 can signify a significant proportion of neuropathic pain. So I thought there was an element of neuropathic pain here. And they ask burning, tingling, light touch, sudden pain attacks. This is an important one. If you get pain at night or unprovoked pain, you've got to ask yourself, is there a neuropathic component to the pain? A couple of other things just to note: not a smoker, drinks very occasionally, was just on some Palexia and some paracetamol, so very simple medications. The screener and opioid assessment for patients with pain, SOAP as we call it, we do that as part of our questionnaire as well. And anything more than 4 suggests that there may be risks of giving this person opioids, which is a discussion that we'll have at another point. Abilities, so this is your self-efficacy. If somebody's got severe pain and they're really debilitated by the pain, everything focuses onto the left-hand side of the screen, so they're not able to enjoy a good quality of life. Somebody that's doing well, everything's on the right-hand side, and this person, everything was pretty much down the middle, so still able to enjoy a reasonable quality of life, and if I remember correctly, they were still working as well. And this is the DAS-21, the screener for stress, anxiety, and depression, and she came across really well, but even so, when we looked at the DAS-21, there was levels of stress, anxiety, and depression. Thoughts and feelings, that's your thoughts around your pain, your feelings around your pain, so catastrophic thinking, and they scored 12 out of 52, so relatively low, but nevertheless there. I examined them. I thought that there was a mechanical element to the pain. I thought there was facetogenic pain, so pain in the left facet joint below the fusion. There was pain on movement, there was pain on palpation of that facet joint, so there was a nociceptive element to the pain. The supraspinatus and infraspinatus muscles were tender to touch. There may have been some myofascial trigger points in there as well, because movement had changed. And I definitely thought there was a neuropathic element to the pain as well, so there was post-fusion non-compressive radicular pain in the T8 dermatome, and again affecting the little and ring finger. There was some mild functional limitations and some stress and anxiety and depression. So that was my assessment of this patient. Now, it took me about 45 minutes to make this assessment, because an initial consultation in pain takes that long. There's a lot to take in. There's a rapport to develop and a plan to put into place as well. Formulating a strategy and a treatment plan is the discussion on another presentation lecture, but just to touch on things, you want to assess the flags and deal with them. The red flags to a specialist, yellow flags to a psychological pain management team. Blue flags and black flags, just very important to be aware of, and even orange flags, do I need to engage a psychiatrist in the treatment. Briefly touching on some pain management strategies. There are medications to use. There are sometimes interventions that can be used if first-line therapies are not effective. Physical therapies, there are many things that a good pain physiotherapist can help with. There are many things a good functional therapist can help with. So that's a pain occupational therapist. And of course, psychological therapy is vital for most people with chronic pain as well. That's just the rough treatment algorithm that you can step into for these patients. And again, discussion of another lecture. This is what a treatment plan might look like. Starting with step 1, you're going to focus on lifestyle. You're going to focus on non-opioid medications. This is the wellness part of pain management, which we always forget about, or I see being forgotten about in some instances. There's the physical restoration, emotional activities and approaches. Simple. At all times, you're thinking about the bottom aspects of the graph. You're thinking about rehabilitating patients. There's always got to consider that no matter where you are in the treatment algorithm. Come back to what rehabilitation needs to happen. The side is empowering your patients and giving your patients information. The more information they have, the more knowledge they have. The more knowledge they have, the more in control they are. The more in control they are, the better they get. And those are the very fundamental basics of pain management. Sometimes you might step on to step 2, so some forms of interventional therapies, if and when appropriate, governed by patient and science and how they're getting on with step 1 therapies. Sometimes neuromodulation or nerve stimulation can be considered in some forms of refractory pain, but again, it's not step 1 or 2, it's step 3. And then step 4, usually quite far away. I've just put it there for discussion purposes at a later point. Opioids may be considered at some point, but again, a huge different discussion for us to have. That's an example of a treatment pathway. Finally, when I talk to a lot of GPs, they say, when can I engage or when can I refer to a pain specialist? The answer is have a pain specialist or a group of pain specialists that you can turn to when you need to. And think about your patients in terms of when I can engage a pain specialist. So there are specific pain conditions. There are specific issues of pain medications that you can consider, even some allied health issues. And of course, we can help out in the preoperative phase. So let's go through that just in turn. So there's specific pain conditions. Now that you have a handle on pain conditions, is it a nociceptive, neuropathic or nociplastic pain condition that's not responding to initial lines of therapy or first lines of therapy? Consider a pain specialist. But there are specific neuropathic pain conditions you should think about getting a pain specialist involved in. Chronic pain after surgery. And that's pain after you'd expect surgical healing to occur. And the definition of pain after surgery is roughly about 2 months, not the average 3 months. Failed back surgery syndrome, a terrible term to define chronic persistent pain after spinal surgery. Please think about getting a pain specialist involved. Complex regional pain syndrome, it is vital that you think about getting patients with CRPS to pain specialists early. We have a treatment algorithm for CRPS. If we can see CRPS patients within days and weeks, we can get them better. If we see CRPS patients after months or years, it's much harder to undo that neuropathic pain. So any form of neuropathic pain that appears to be refractory, get them to a pain specialist. Radicular pain that's not responding to treatments. Headaches and facial pain, very important because they can really debilitate patients in terms of psycho-emotional aspects. So think about a pain specialist early. Peripheral neuropathy, visceral pain, doesn't always need a gastroenterologist or a gynecologist. Think about engaging a pain specialist as part of that team. Pelvic pain as well. For some nociceptive pain conditions should be managed by pain specialists. So joint pain, facet joint pain, sacroiliac joint pain, spinal pain, non-operative joints, so hips, knees and shoulders. Think about it. If a patient's too young or too old for surgery or not deemed appropriate for surgery or doesn't want to have surgery straight away, think about getting them to pain specialists. There are things that we can do to help. Nociplastic pain, we've mentioned those widespread pains. Pain medications, you're going to start patients on pain medication, we'll discuss at another point, but if they're not responding to first-line therapies, think about a pain specialist. If they're getting side effects from medications, think about a pain specialist. If they have significant medical comorbidity, think about a pain specialist. Opioids, big discussion. We'll have it at another point. But caution, think about pain specialists if you're using greater than about 40 milligrams of O meds per day. That's oral morphine equivalents. And almost certainly seek pain specialists if they're aberrant behaviors or the morphine equivalent is touching or more than 100 milligrams a day. From the allied health perspective, if there are yellow flags or they're not responding to simple allied health avenues of treatment, think about pain management specialists. And some patients, and we normally get this from surgeons, if there's a preoperative couple of issues that need addressing, we'll see patients in the preoperative phase, put together a perioperative plan of action and then a postoperative plan of action. But if patients got moderate to severe pain, high levels of anxiety, they're on lots of medications in the preoperative phase, think about engaging a pain specialist. There are many other considerations, but ultimately if you're not making progress on a couple of the first steps, think about talking to a pain specialist.